Buenas tardes a todos. Vamos a seguir con la...
Good afternoon, everyone. We are going to continue with this session. The entire marathon for these timings. We started off at 9 a.m. in the morning. The meeting on IO in lung cancer, where we have been enjoying today several prominent presentations of keynote international and national speakers. I'm not going to mention anyone in particular, but prominent speakers where we have learned a lot and we enjoyed a lot. One of the most important values of this meeting were the speakers and the discussions. And the time now has come to start a very interesting aspect, the clinical practice. We're going to listen to 3 clinical cases. Luis Pajares will be the chair. Thank you so much, Luis, for sharing with me the co-chairing. Marga Ballén from the Santa Creu Hospital of Barcelona, Isla Loza Nobleza, and Manolo Cobo from the Malaga Hospital are going to introduce 3 topics, and we're going to have the opportunity to comment with them. We will engage with an initial talk with Marga because she has a prior commitment. Fantastic. And we're going to see how these cases are solved by very skillful and professional expert colleagues in the field of lung cancer with the Spanish Cooperating Group and other groups. And not because of the age, but because of the years of seniority, they have an awful lot of knowledge and experience. Luis, I give you the floor for a few seconds, okay? So you can see whatever you deem necessary. I believe it is a wonderful initiative. Today, the session has been most entertaining, fruitful, where we have revised what today and what we must do and I think it is a good moment, this session, to set it in motion. I'm sure the clinical trials will be a very similar study. We have to encourage people to become interactive in these discussions, and with Marga's case and the case of Manolo Cobo and Lola Isla. And I highly encourage all of you connected online, please do not miss the final conference today from Carlos Cordon, a very interesting talk. Please do not miss it. Marga, you have the floor. Hello, good afternoon, everyone. First of all, I would like to take the opportunity to thank the ECHO Foundation and its organizers for counting on me for the presentation of this case that I'm going to display on the screen now.
Bueno, voy a presentar un caso de un paciente.
I'm going to do a case of a patient with an aggressive disease. It is a 72-year-old male with no prior background. He's a former smoker for 12 years, an accumulated IA for 40 packages a year. First symptom, IRV with antibiotic treatment, a chest ray displayed a right part, and it was referred to the lung cancer of the Sampa Hospital in July 2020. He was diagnosed with adenocarcinoma with this pattern T4N3M1C, stage 4B. Bones, lungs, and liver were affected with a PD-L1 expression of 50% with a KIT 22C3. The tests performed were EGFR, ALK, and ROS1 were negative. He had a stenosis of the superior vena cava, while he was prescribed with steroids. But it's important to mention that that was prescribed from the pneumology service, and the patient was asymptomatic. When he came to the Department of Oncology, we performed a foundation test, and we found a mutation of STK11. He has a high PD-L1 expression. He could be a candidate for immunotherapy, but he has other adverse factors. Having received antibiotic treatment could be a worse response to immunotherapy, as it is reported by literature. And we also know that having received steroids, and because of the comorbidity, also worsens the diagnosis, and this is a work that we have recently published. As far as the STK11 mutation, the inactivation in a tumoral cold microenvironment with less density. This is a potential mechanism of resistance to immunotherapy in NSCLC non-squamous with bad prognosis in NSCLC with an alteration of the protein. Literature says that there are many clinical trials, retrospective trials, where we have analyzed the role of the STK11 mutation in order to assess the response with the treatment with the immunotherapy. And those patients with that mutation have a shorter PFS and lack of benefit from addition of pembro to chemotherapy. These are the findings presented in the World Summit last year. This is the MYSTIC trial for patients with durva only, are those durva with tremor. This is a work presented in the ESMO Open Summit, recently published, and it observes that the contribution is a factor of bad prognosis. On the one hand, we have a bad response factor or bad prognosis for lung cancer in general. But recently, we also presented data of the Kino 042 study with a PD-L1 above 50% with pembro versus chemotherapy. And the key conclusion of this analysis is that presenting an STK11 mutation didn't worsen the results of patients receiving pembro as opposed to prior studies. And the authors concluded that patients with an STK11 mutation and the treatment with immunotherapy could be the standard as well. And we have, with these patients, started with pembro in August 2019. He had asthenia, anorexia, lost weight, dyspnea, chest pain, cough. He was receiving dexamethasone that we removed. He started the treatment, and after the first cycle, he was received because of brachiocephalic thrombosis, bilateral. He required the placement of a prosthesis, bilateral prosthesis. Therefore, the patient received the anticoagulant, antithrombotic treatment. We had to delay the second treatment, but the second cycle of DEXA was received. And after the second cycle of DEXA, we saw a worsening of the disease. This is the initial mass. And what we see here is the growth of mass with and the onset of a node and the another node. We could assume that this patient had a non-confirmed progression, and this is what the clinical practice says. It could be a pseudo-progression. What is a pseudo-progression? The growth of injuries or the onset of new injuries after a response, especially in melanoma, but also in lung cancer. It is not a real progression. There's an infiltration of the immune cells, but if it's not a real progression, it is important for a patient to have certain stability, and they do not require an increase in the symptomatic treatment. The answer is received between 4 or 6 weeks afterwards. This is very well described. The IRISist guidelines, and it is very well established what shall be done and how to determine if the patient it has undergone a real progression or a stability based on if the new injuries grow or others grow or from the first time. Things had improved. They had referred that in the last 24 hours he had some major pain on the left knee. With an X-ray, we saw a lithic injury. He had a PET, and this in our hospital goes a little bit behind the hips, and we do not really know if this injury was there or not. We supplied 8-gray radiotherapy, and the patient underwent a treatment. We repeated the test. If the patient was in progression, we did not want to lose it. So the lung mass had a reduction. The suprarenal metastasis had reduced, and there was a previous sacral reduction. There was a stabilization of the illness because the new injuries hadn't grown, and the former injuries had reduced. There was no onset of new injuries, and the patient continued treatment. Before the 4th cycle, patient had improved substantially, and the pain was controlled with morphine that we had administered, and the patient did not have any news. And here the thing is that perhaps there was a abscopal effect of the radiotherapy. And this is the reduction of the antigenic expression. When we administer this in the injury, they release antigens that activate T cells, and they travel through the lymph node, and there is a diffusion up to the peripheral area of the T cells, and it can act upon other locations. Here we have a different way of seeing what I just explained, releasing antigens that are captured by the dendrite cells. T cells are activated, and when the T cells are activated, perhaps there is a blockage because of the TD1 that is inactivating the cells recognizing the cancer cells, and this is where the anti-PD-L1 antibodies will act, and this is the combined effect of RX and radiotherapy and immunotherapy. This has been well described in literature. There are many clinical trials in lung cancer trying to understand the abscopal effect, and in the upcoming years we are going to gain additional information on this phenomenon. As far as our patient is concerned, it has continued receiving the treatment with pembrolizumab. In December, we observed a partial response that has been maintained in the May control patient, only referred a small gonalgia, which is the earliest symptom he's referring, and the latest control, he had a 50% reduction. The only thing he requires are random antibiotics for the treatment of gonalgia. This is what we had in October when we confirmed that the patient had stabilization of the disease. The suprarenal part had reduced, and the left psoas muscle had reduced, and here we had seen that the reduction in the disease, the suprarenal was fine. The pre-sacrum node was not seen, and neither. And this is the latest control in September, and where we have seen a major reduction of the entire disease that he was presenting. So interesting points here is that the patients from start, for the features, this asymptomatic disease, we wouldn't have considered him as the best candidate for immunotherapy from start, as monotherapy associated to steroids, antibiotics, and the mutation of the STK11. But because of the evolution of the case, we believe we nailed it with the treatment, and the evolution has been satisfactory. Thank you very much for your attention. Thank you very much, Marga. Luis, do we have any time for comments? These cases are surprising to see how they evolve, the different locations of the tumor. Apart from the abscopal effect, which is very interesting, we will have to remember the New England publication 2 years ago, doubting there was the abscopal effect whatsoever. But there are cases like this one that make you rethink about it. Didn't you think about performing a biopsy in any location in order to understand what was going on?
Mira, la verdad
this patient, the new injuries he was presenting were easily accessible. The only injury that could have been a possibility was the suprarenal injury. But when the progression happened, when the patient was suffering the thrombosis, we thought it wouldn't add a lot of benefit, and we wanted to do another cycle because we thought that it wasn't working, and on the CT scan we wanted to see another progression, and therefore we saw a reduction of it. Would you undergo a monotherapy in a patient, next patient like this? The way things are at the moment, it's very difficult to do this with a high PD-L1 patient out of clinical trials. If I could, I would have treated him with chemotherapy plus IO, because he had a lot of symptoms. He would have benefited greatly from a chemotherapy immunotherapy. I know you are running out of time. Unless you have any comments, let's move on to the next speaker. I think it is very relevant, and I couldn't agree more with what Marga said, but probably these patients, you would like to apply chemo immunotherapy, and at the end of the day, this is a very odd situation in which we are living against the reality of evidence of what we believe what we need to do, because there's very stringent regulation in that sense. So in some cases, we have seen the possibility to expose them to first-line chemotherapy, and after 10 minutes, second-line immunotherapy. I haven't had a chance to do this, but I will take it into consideration.
Un poco pactado con nuestro sistema, sobre todo teniendo en cuenta el valor marginal.
Taking into consideration the marginal value, the cost of chemotherapy versus immunotherapy. Well, it wouldn't make sense. And I believe it's not very sensitive. Do you often perform genomic studies of patients, KB1 or mutational burden in order to help you in the very high PD-L1 patients to understand if you need to have chemoimmune or no? I mean, we can only do genetic studies in very few occasions, but it's not something we do very often. For me, the guiding factor is clinic more than genetic factors because I am missing them. So we trust clinic more. Sorry, Carlos, I was interrupting you. I would love to continue discussing this with you, but we are forced by the discipline of time. Marga, thank you very much indeed. Thank you all for counting on me. Thank you. Goodbye. So the next speaker, Dr. Lola Isla, Dr. Island in English. She's going to illustrate a very interesting case about brain metastases and the management thereof.
Buenas tardes. Agradecer a la...
Hello, good afternoon. I would like to thank the ECHO Foundation, Carlos Camps, for the opportunity to be here today in this most interesting meeting. And it is a pleasure to share it with such friendly colleagues like Luis Pajares, who's always treating me so well. And Carlos isn't unfriendly, is he? Yeah, well, in the way he's introducing me, he's not as friendly. So this is a clinical case. The profile is as follows. Brain metastases, treated with IO. She's a woman.
Vale, bueno, pues esto es el caso clínico.
This is a case report. A 58-year-old female, active smoker, 35 packs a year, arterial hypertension with no immunosuppressant or underlying autoimmune disorders. In September 2018, she was referring weakness in the right body, normal laboratory assessment. She was reflecting a left posterior parietal cerebral nodule of 2.1, a 3 centimeter right cerebral vermis mass. The CT scan early identified an injury on the lower lobe lung of 3.2 centimeters. On the PET CT scan, a 3.2 right lobe lung. We had 2 core biopsies and 1 EBUS. They come back negative. Finally, we needed a surgical biopsy using VATS, and the diagnosis is adenocarcinoma lung, PD-L1 negative. These ladies also performed an NGS platform in a solid biopsy. These are the findings, the confirmation of the negativity of the biomarkers that we had determined. There are no other additional actionable driver mutations, and these are the intermediate TMB 18 mutations megabot. And there is also a CRAS mutation, G12V. CRAS is related with greater efficiency immunotherapy. This mutation in particular has a lower effect in terms of efficiency. There is also a co-mutation of RASK1, which is related also to certain publications with a lower immunotherapy efficiency. This information has been given by the platform in relation with the immunotherapy activity. The clinical stage T2A4B, the CT scan taken in September 2018 with left node and the brain metastases that are very obvious in the PET CT scan. And what is the treatment? Clinic worsen with instability because of the cerebellar metastasis, and because of the delayed diagnosis, we had to perform a palliative cranial radiotherapy. In November, we already had the final diagnosis, and that's when we started to provide the first line of treatment, standard carboplatin, and then maintenance with pemetrexed. We administer those 4 initial cycles and then 11 of maintenance toxicity. Edema grade 1, grade 2. There is a very good control of symptoms, stabilization of the disease. The PFS is 11 months. There is an asymptomatic progression that is identified in different tests with the increase of cerebellar injuries. And the PET tag, apart from the right node mass, we have identified a 2.5 centimeters metastasis. This is the MRI after the treatment with chemotherapy with a lot of brain injuries. The PET CT scan reflected the onset of the suprarenal injuries and the right lobe injury. We started the second line therapy with ATE every 2 weeks to 19 cycles. We are still doing it. We no toxicity present, and the response is received with the 3rd cycle in December 2019 with a PFS 13 months. This is the MRI last month in the response assessment, and we can observe there is very little there is very good brain response of the brain metastases. And at the level of PET CT scan, the injury in 11R disappeared, and the suprarenal injury. However, the right lobe injury maintained. By way of summary, we started the first line of the treatment with carbobot plus PEME for 11 months, and the second line therapy with atezolizumab for 13 months until now. The OS has been 24 months year to date. This is the therapy and efficacy, the different timeline highlights and the responses, plus the overall experience 24 months. Things to be discussed to carry out an NGS platform with that woman for the usual test, the second line of treatment in stage 4 for NSCC brain metastasis. Could it be useful to perform an NGS platform upon diagnosis? I think the answer is yes. This is the consensus where they identified these biomarkers, the clinical practice for adenocarcinoma, and for other emerging markers, ERT, MET, FRET, TENEC, and the ESMO guidelines set up the mandatory need to identify, test these biomarkers, and they have recently included in the recent update the reconfiguration of Intra. Performing single test versus NGS, this is more and more favored in the guidelines as it clearly shows, if possible, NGS is recommended. And recently we have seen the publication of the paper on ESMO for adenocarcinoma lung cancers. It is also advisable to introduce in the clinical practice NGS. The second line of treatment in stage 4 NSCO CL negative with CNM meds and immunotherapy. The ESMO guidelines recently updated have this indication of atezolizumab with this drug on the second line of treatment with that level of recommendation, and the ESMO clinical benefit is 5. Atezolizumab with indication receives the approval. This was approved in Lancet. This is the design after a first or second line of chemotherapy. Patients are randomized dose versus atezolizumab. We can include also patients with brain metastasis that are asymptomatic treated. The endpoint is the overall survival, 13.8 months. Our patient has already met 24 months. Brain metastasis and immunotherapy satisfactory results. In these ESMO guidelines, we have seen the possibility, obviously, to use RC, and so far there are limited data about the efficacy of immunotherapy of patients with non-treated brain metastases, because these ones appear in almost 44% of the patients throughout their disease, so it is very frequent. This is a paper of ASCO 2016, many years ago already, where it already said that the microenvironment of brain metastasis differs from extracranial metastases, as the brain is a highly regulated organ in terms of immune response, and there was a immune checkpoint inhibitors that have shown intracranial activity in early clinical trials for patients with brain metastases from small cell and non-small cell cancer, lung cancer. And I have brought this paper from our colleagues from the Hospitalet hospital that has been recently published, Immunotherapy and Brain Metastasis, where they talk about the presence of reactive astrophytes and associated macrophages that are responsible for the tumor progression and the immune evasions in patients with brain metastasis or NSCLC. They are usually cold with a very low PD-L1 expression and with a less infiltration, and they require the characterization of immune phenotype of brain mets interactions in cancer cells in order to try and improve the results of immunotherapy, being more accurate in this treatment after this study.
In the treated patients, the percentage of patients with brain metastasis included was around 10%. Very few patients and highly selected. They were usually symptomatic and previously treated. In the OAK study, the pivotal study of the drug used for our patient in the clinical case, for this subgroup of patients with brain metastasis, hazard ratio was even better than in brain metastasis, 0.54. In this slide, which also comes from a review from Hospitalet, we can clearly see the results of phase 3 studies in first and second line, with and without brain metastasis. The results are quite comparable. I have to say that in clinical studies first stage, we're allowed to have with asymptomatic metastasis which have not been previously treated, such as in Keynote 457, but not the case of Keynote 27 or Keynote 024. The intracranial efficacy is comparable of extracranial efficacy in the disease. This is another study available to us, published in Lancet Oncology a while ago. It's NSCLC and non-treated brain metastases that have received pembro. The NS36 patients percentages, as you can see here, is around 33%. This is a safe and active drug in the brain with an activity comparable to the rest of the systemic disease. There are some other studies that analyze what happens in this particular population of patients with brain metastases, untreated and asymptomatic brain metastasis, such as checkmate 817 in this cohort A1 of special populations. In these patients in first line, they received Nivo and E. In this study, the cohort A1 includes patients with brain metastases that are untreated and asymptomatic and receive this scheme together with other special populations such as HIV positive or renal failure. Sorry, liver failure. Here you can see the results are not as good as in the general population. The conclusions in brain metastasis and immunotherapy is that we have limited data because patients have been selected in order to include them in the clinical trials, and there were very few patients, but the results are very positive. We see that immunotherapy is active, and perhaps there's the need of characterization of the immune phenotype of these patients with these locations of the disease and study the interactions with this immune system to design a more precise strategy. Thank you very much. Thank you, Lola. I think it's a very interesting case. It shows what we see more and more in our clinical practice. Usually, when you have a patient in first line with brain metastasis, what do you usually do today? You use radiation first, you start directly with chemo and immuno, if that's what you're going to do. What's your approach right now? Well, intracranial radiotherapy, I don't like using it. My experience is that it highly deteriorates the patient very frequently. Generates asthenia associated to the symptoms they already had, instead of improving the symptoms that we want to control, because otherwise I wouldn't think of it at all. It doesn't really achieve this, and it worsens general status, and it forces you to keep steroids for longer than you like. I usually use intracranial endotherapy if the patient is asymptomatic with many brain lesions, such as this case. And I always try to avoid doing it. But there have been cases in which I've considered SRT, but in most cases, overdiagnosis, I maintain steroids. I discontinue them if it's possible before starting the treatment, which would be chemo and immunotherapy, because the mutational burden is supposed to be high, right? Sometimes brain metastases are a finding, and it happens in clinical trials. We are requested to carry out diagnosis tests in the central nervous systems, and we find them. For me, there's no problem if the trial allows the patients to start. They don't receive anything at brain level, because what we want to see is the effect of the therapy at that level that we see it exists. Carlos? I think that perhaps we can move on to our last case, Dr. Manuel Cobo from Regional University Hospital in Malaga. And perhaps at the end, if I have time left, we can have a small discussion. Manolo, do you want to continue?
Pues sí. Bueno, en primer lugar, quería agradecer, por supuesto, a la
I would like to thank ECHO Foundation for their invitation in taking part in this interesting and long meeting. I'm going to present a case. When I need to congratulate the previous speakers, because they've presented very interesting cases and they're well documented. My case is more mundane, so to speak, with less background, perhaps, for the explanation for my decision. This was an advanced lung cancer with liver infiltration, and PDA1 was low. It's a male, 59 years, a diagnosis, smoker, 30 packets a year. Syphilis while as a teenager was treated and cured. ECOG PS was 1, but however, he had signs of superior vena cava syndrome with fascial edema and collateral circulation. He came to the practice for these reasons: cough, some discomfort, the chest, and moderate constitutional syndrome. And nucleic expectoration, which was slight. There was mediastinum thickening, and in 2017 he had a mass in the superior right lobe, more than 5 centimeters, with a big adenopathic mass, which was provascular, that surrounded the vena cava up to 7 centimeters. And there were other adenopathies, provascular adenopathies to the right. The PET-CT, well, there was a mass in that place, and this adenopathy conglomerate. We carried out bronchoscopy. It was carried out twice. The result was negative, and coordinated biopsy. We did it with the material we had back then. EGFR, ALK mutation, ROS1 were negative, and PDL1, which is the technique 22, the C3, it was negative too. These are the images from the PET-CT. You see the main mass, and the huge adenopathy conglomerate, which was provascular, with the infiltration of vena cava, and adenopathy which was right and left, and for that reason it was T2B. The new classification would be T3 because of the adenopathies, contralateral adenopathies, and 3M. Superior vena cava syndrome, ECOG status 1, and negative mutations, PDL1 below 1. The treatment suggested was chemo and radiotherapy. The mass was big, the functional tests were good, so we applied this. And in this case, it was paclitaxel and carboplatin. The patient became stable. His vena cava syndrome was stable, so we didn't apply aggressive radiotherapy. It was a short fractioning. With short fractioning, etc. It was a chemoradiotherapy, the standard one. And after finishing a chemoradiotherapy, we applied another course of treatment as a sequence. Esophagitis grade 2, no delays, no dose reduction. We've seen that this scheme was applied in July 2017. And there's a partial remission, which was quite significant. We see the result after treating with chemoradiotherapy. You see signs of a volume reduction to the right lung and a big decrease of the mass and the adenopathy conglomerate. They virtually disappear, although there's some persistence there. The patient continues to come to follow-up, and in November 2018, there's a progression. This lesion grows in the thorax, where it was in the past, which compresses the vena cava. There are many collateral lesions, and besides, there's a systemic progression. Right paravertebral mass in the right lobe, and suprarenal adrenal nodules. Also, the superior vena cava syndrome worsens, although still moderate. And there's something here from a clinical point of view, which is an alteration of the visual field in the left eye. The eye examination and ultrasound identify metastases. What did we do? We biopsied this new metastasis, which was in the liver, for a sequenciation. In this sequenciation, by ion torrent, Thermo Fisher, we didn't detect any mutations acceptable to be a target. There was only a mutation of P53, and we redid PD-1, which was below 1%, with the same technique. These are the images of the progression, and you see how it was reduced at a graphical level, the conglomerate and the mass, and the collateral ones, and the deletion at liver level, and the adrenal adenopathy and the peripancreatic lesion. After finishing the chemoradiation treatment, the last dose of platinum, we proposed a retreatment with the scheme based in platinum. We combined chemo and immunotherapy, carboplatin and pemetrexed and pembrolizumab. Since November 2018, and after 4 courses, the patient continues with maintenance treatment with pemetrexed and pembro. Courses repeated every 21 days until progression or unacceptable toxicity. The patient tolerated very well, just asthenia grade 1 in every course, and there were no delays and no dose reduction. This is the background for this. Not much to be added. This was 2018. We already had data from Keynote 021, and also data in the long term. OS data. We knew there was a significant benefit here. And also studies from Keynote 189, which was randomized. There were patients with PD-1 above 1%, but also below it, in other words, negative. With the combination, there was an improvement in responses and also in the duration of responses. This was seen in all the categories. Of course, with lower PD-1, the results were lower, but they were there. This improvement responses was there even when PD-1 below 1%. If we consider the curves of duration of response, we see the same thing. There's an increase, an improvement in the median in patients with PD-1 below 1%. We know that there are data that show that this benefit of overall survival is seen in the long term. You see it in every subgroup for PD-1 at every level, and PFS. Most patients there are benefits in each subgroup of for PD-1. And also data from last year. When you analyze risk factors such as brain metastases, Dr. Isla has mentioned, and liver metastases that we know, it's a criteria for much worse prognosis, whatever you do. And in this study, it was seen that patients with and without liver metastases still had a positive impact in survival. there were immune-related toxicities, but immunotherapy did not increase toxicities. Let's go back to the clinical case. This patient, after 4 courses, there was a partial remission, biologically proved, and an improvement of syndromes of the Spiri-Vina-Cava syndrome, and this impairment of visual in the visual field disappeared. We're speaking about this TAC carried out in January 2019. These are the compared images of this assessment after the first 4 cycles, in which we clearly see a decrease of thorax lesions, the mass and the conglomerate, adenopathic conglomerate. We see the reduction of size in the liver lesion and a reduction in the size of the adrenal lesion and the peripancreatic lesion. He was not referred to the ophthalmologist to examine the fundus because the patient had no problems anymore, had no symptoms. This CT was from the date. In the next follow-up visits, there were no changes compared to this CT in January 2019, so almost 2 years ago, and the patient follows a maintenance treatment with Pembro and Pemetrexed without accumulative toxicity, without relapse, and with a very quality of life. So my comments, the scheme of Pemetrexed, Pembro, and Platinum, it's another one. And in 2018, it was the reference scheme. The data obtained were spectacular. Today, we know that we have other possibilities, such as combining platinum, paclitaxel, and bevacizumab. But the results of the study were highly relevant for this combination of chemo and immunotherapy, and there were benefits for the immunotherapy combination in patients with no expression of PD-L1 and with patients that had liver metastases, with the results regarding safety and tolerability that are manageable. And with this spectacular result, this is a patient that had not been treated for a year with a combination of platinum. And this encourages us to continue even with first-line patients, even with horrible prognosis. We know that these patients, if he hadn't responded, he would have died very quickly. And there's been a spectacular remission after 2 years of starting the treatment. So this is what we consider a long survivor. Thank you very much for your attention.
Venga, Jaime, mil gracias. Un abrazo. Sí, aquí como podemos.
Thank you very much. It was a very interesting case. Carlos, do you want to add something? It's quite the example of the benefits of immunotherapy. Perhaps just to say something that may be questionable, the value of maintenance of Pemetrexed in an immunotherapy context. Are you really sure that we should do this or not? I don't know. These are the data we have. I'm pretty sure it's not an intention. There are data that suggest that we should continue to insist with chemotherapy, and we know what that Pemetrexed in maintenance, it had the data it had, but insisting with chemotherapy, I think it's not going to have this impact as benefit, and maybe it could be even counterproductive in patients that you see they're having a benefit with immunotherapy. It could be counterproductive. Of course, this has to be proven because data are data, not just with intuition. You need a background, a scientific background, because many publications lack this. And this is something that could be counterproductive, as I was saying. Right now, it looks like chemo is great to do a lot of noise, but I'm sure about maintenance. Perhaps the basis is not that clear for maintenance with chemo and immuno. I think the hypothesis that maybe maintenance chemotherapy doesn't necessarily help. The data are there. It is true. And I think that in order to be cautious, we should prove that it's worthless. During COVID, some patients we suspended their maintenance treatment with pemetrexed. They were changed to Pembro every 6 weeks. It was a particular situation. We wanted to avoid neutropenia, having them come to hospital, etc. And I guess many of us have had progressions. We'll never be certain whether it would have happened or not. But I have some feelings here. Yes, right now it's a matter of feelings, as Luis is saying. We need to manage human beings. So feelings are also important besides evidence. Lola, what do you do in these cases? I was going to say something. I've had a significant number. I took part in Keynote 189. I had several cases of renal toxicity. And after 5-6 courses of pemetrexed, I decided to discontinue and continue with Pembro or placebo. I don't know. But there were patients that fared really well. The renal issue was solved because it was due to pemetrexed. And I had patients that are doing great. After 2 years, they're still okay. My experience in Keynote 199 was that. But then in the clinical practice, I see things. And this morning, I've seen a lady. We had a pemetrexed toxicity, leads completely swollen, legs with edemas. And I said, okay, here we go again after reducing pemetrexed. And with Pembro, she had no problem. It is true that most likely after some point in time, it wouldn't matter to maintain pemetrexed, but as you've said, we haven't proved it. And it's true that studies are done as they are done and they get the results they get. And sometimes if you have too many feelings and low evidence, I don't know if we should do that. And I'm concerned. In a situation of toxicity, you need to do what you need to do. And this was the case. Keynote 199 was very positive. But there's a difference between discontinuing right from the beginning or discontinuing afterwards, because when the study was done with maintenance. Yeah, it's okay, everything that you're saying. It's nice to express these comments because this was what allows us to move forward. We don't just need to accept data, we need to ask questions about what's best for our patients. The common point of these views is that we need to study. Okay? Yeah, totally, completely agree. Hey, Manolo, Dr. Isla was very assertive with NGS. What do you think? What do you think about this?
Jordi, Ramon, what about you, Manuel? We do NGS every time we can. Every time we can. The problem with it, as you all know, is that the sample is always very limited. And in our experience,
no son tanto los pacientes que suele tener material tumoral suficiente
you
como
are lacking sufficient tumoral material. When we have clinical trials, when you need to submit the sample to headquarters in order to include them on the clinical trial, this is a bit confusing. And then we collect these in order to see if there is material, and we try to do something extra. But the truth is that do not do it with all the patients. But I believe this shall be implemented. We have captured the genetic alterations that weren't expected. We have been able to reconduct patients, derive them to clinical trials, and I try to diversify the sample for NGS and for any kind of clinical trial. We have at the university a sequencing device that we can submit locally, a panel of 50, and we have quite a lot of agility. Oh, good then. And this is a topic for Manolo and Lola. Treatment until progression, or what? What do you do now? What do you usually perform? Or what do you think? I'll give you the floor. Being very strict, we will have to do as they do in the pivotal clinical trials. If they do it until 2 years, it is very difficult to go beyond what the recommendations say. In fact, when treating a patient with the chemoimmunotherapy, in order to do it, we are very strict with the inclusion criteria, obviously. And this is the same. My experience is that cutting or non-cutting after 2 years depends on clinical conditions and such a clinical feeling that you may have with a specific patient. I don't think there is any problem whatsoever when we have information. After 2 years, we have had a complete remittance, not a radiological one, but there is evidence that there isn't any cell activity with the biopsies, or even with PET CT scan. We can stop with no fears whatsoever. The problem, however, is when we continue to see that my experience when I discontinued in first and second line with a patient that still had active disease was not very good, because when the patient progressed, non-reintroducing any hasn't been positive. There are several theories about this, but I particularly think in the most striking experience, I do have a patient for almost 8 years, and I apply atezolizumab because I have pulmonary mass that is very active, because then grows, it goes down. It does not progress or respond, but it has been doing so for the last 7 years. I know it is active, and I'm afraid of removing it. The growth will probably have a biological explanation. So there's still certain brain growth that can be controlled with infiltration, but it's evident that this growth and decrease is the reason why. And it is very random in the follow-up, and I haven't removed it. Almost 8 years. Manolo, we have to finish now.
tenéis que pasar al siguiente. Yo a los 2 años...
I would be very short and sweet because I suppose you need to move on to the next one. Those reaching 2 years, I suspend treatment because this is how pivotal trials do it. Pembroke do it, but also almost all of them. And I believe we are missing clinical trials that compare until progression versus rechannel challenge, but what the pivotal studies do. Thank you very much indeed. Thank you, Norma. Manolo, Luis, we have to finish now because you need to present Dr. Carlos Cordon. We only have 5 minutes delay, but we cannot expand it any longer. Thank you very much indeed. I'd like to thank our distinguished colleagues. You have presented 3 very interesting cases. 3-4 years ago, who would have told us? Thank you very much. I'd like to thank the research and innovation for incorporating these type of treatments. It is unbelievable. We have a lot of questions to answer, but common sense tells us not to make serious mistakes. Thank you very much for taking care of our patients. Let's continue with Carlos Cordon. Do not miss it. Luis,